Thank you, Adela. So I will introduce the concept of the Bariclip. Probably you heard about it. It's still an investigation procedure. We are performing now currently in 12 countries, mostly in South America. Mexico is the first country, and in Europe, mostly in Italy. I did cases in Dubai. I trained surgeons in Saudi Arabia, in Bahrain, in Belgium, and some other place. And in Tunis, we did some case during a workshop a few years back. So the concept is, Rami Lutfi from Chicago said it's clipping, not cutting. Instead of cutting the stomach with a stapler, almost at the same place, you are putting a large clamp. So what is made this clamp? It's a skeleton of titanium covered by silicone, almost 15 centimeter length, 11 millimeter wide, and on the distal part of this clamp, the 2.5 last centimeter are open, are more like a gastric band. And so it will allow the gastric juices coming from the exclude part of the stomach to go through this last portion on the bottom of the clip. So during the last IFSO in Miami, the first day we did a sleeve consensus. We were 4 there. On the Bariclip, and it was mostly to discuss. It was an expert opinion meeting to discuss more on the Bariclip, the technical aspects, the tips and tricks, complication, how to manage a complication. Because today results, we have few results, few publication, and at that time, principally, it was difficult to conclude and to do a real consensus meeting. But I can announce today that we will do the second consensus meeting or expert meeting during IFSO Napoli in, I think it's August, September 2023. So what is the Bariclip? It's a restrictive procedure. So we need more data today to conclude, and we need as well some hormone study. And this hormone study will arrive in a few months. It has been already done in Lille University. So I told you 12 countries. In July 2022, almost 1,200 patients has been operated. I will show you a short video, if you have the video. Not sure, no. So we'll try to, I don't understand why, because the video was on the presentation. So I will give you the first result published in 2017 on obesity surgery. It was done about 117 patients. This series has been realized in Dominican Republic by the inventor of the Bariclip, Dr. Moises Jacobs from Miami. And the surgery has been done with Nathan Zundel. So 117 patients, and you can see at 1 month, an average of 51% of excess weight loss, and at 2 years of 66% of excess weight loss. It was the first series published in 2017. So I tried to collect data coming from different countries, 109 patients, and we have almost the same result. At 1 year, excess weight loss was 57%. At 1 year and a half, 63%. Very interesting. on the first series published by Moises, the first complication encountered was slippage with 7.7% of slippage. In this second series, we collected 3.4% of slippage, no erosion. Interesting, the rate of GERD de novo was low, much less than with a sleeve, 1.1%. It was, I think, 2 cases on 117 patients. So we had a good result, interesting result. So same, you have with another format, the different result in terms of weight loss. So I will show you, I hope it will work now. I have not the video. I don't know why I have not the video in dynamic. So sorry for that. We'll try to pass after the presentation. So key point of the sleeve, we spoke about sleeve and reflux, now about Bariclip in reflux. We know, and you remind us that sleeve was a reflux maker, and different series, you mentioned 3 to 83%. In the literature, I found GERD de novo 20-50%, and with some series, Grenco and other ones showing around 17 to 18% of Barrett's esophagus. So Bariclip is completely different system. It's a low pressure system, and it will balance the pressure between the gastric tube and the excrete part of the stomach. The dissection on the top of the stomach is much less aggressive, and probably these are the 2 reasons that we don't see a lot of reflux after sleeve, 1.1% in that series. We have now other series with almost the same rate of reflux. In terms of quality of life, we managed to do a study when I was in Dominican Republic. Results are very good globally for 80-90% of patients, but it's almost the same thing with the other procedures. This is a questionnaire we were using, Mored questionnaire, with good results. So you have the different items followed by this questionnaire. I hope it will work. No, so with time, we have changed the technique. I think we have improved the technique by adding a partial plication of the antrum and by changing the suture of the fixation of the Bariclip. Initially, we did 3 sutures on the anterior face of the stomach and 3 posteriorly to fix the clip, but even if we had some suture looks okay, we found 7.7% of slippage, and in the second series, 3.4%. We decided to change this technique by adding some wrap around the clip anteriorly and on the bottom posteriorly. And on the top of the clip, we did 2 additional sutures. And with this new strategy, we see around 1 to 2% of slippage now, so much less slippage with this new technique. And by adding this plication, partial plication of the antrum, we have now better result in terms of weight loss as well. So benefits of the Bariclip. In terms of weight loss, especially at the beginning, we were exactly between the sleeve and the gastric band. Now we are getting closer to the sleeve. It's easy to do an upper endoscopy. You can do during the surgery, after the surgery, and you can explore the excluded part of the stomach. In terms of quality of life, you saw the first results are good for the majority of patients. It's a reversible technique, even if obesity is not reversible. Some patients are asking for that. So it's interesting for some patients, maybe not for the surgeon, but for the patient as well. It's easy to convert. We started to do some conversion, clip to sleeve, clip to one-way gastric bypass, and recently clip to mini bypass. Some of them have been done, and especially in Italy. So working on process, and we'll give you more information in few months, and especially if you are coming to Napoli. I can add that one new paper has been released in Italia with mainly two series coming from two centers, Zingonia close Milano and Rome, with Stefano Olmi and Paolo Gentileschi. And it's at 6 months. It's a very short series, almost 50 patients, if I remember well, 50 patients at 6 months, and they have good result with few complications. And the conclusion was, well, that it was a good technique, but on a short-term period at least. And we have now another paper that just been accepted on recently on the new technique, the evolving technique, where we added this partial plication. We have other papers running, one on the reflux has been accepted, another paper on, so different papers are arriving. So at the end, today I can see it's still under investigation. It's working. We have learned a lot with our first complication and with our learning curve. I really think that we have improved the technique now. We have better results, and we have to work more. Any question? Vous avez quelques commentaires ou questions?
Une question, Patrick. Non, ils entendent. Une question, Patrick. Dans cette technique, je suis entièrement d'accord avec vous que la sleeve comporte le plus grand problème, c'est un système à haute pression, et c'est le problème de reflux. Et que à distance, tout le souci, en dehors de la reprise du poids, qui est commun à toutes les techniques, quelle que soit la technique, et qui a d'autres causes, mais le problème spécifique de la sleeve, qui est l'intervention la plus pratiquée, c'est le reflux. Et que il est encore tôt dans cette technique aussi de dire qu'il y a il y a très probablement moins de reflux. J'aimerais bien avoir de plus des séries de plus grand nombre. Les séries sont de faible nombre, et je pense pas qu'on peut l'annoncer dès maintenant qu'il n'y a pas que le taux de reflux est faible. On peut pas être sûr. C'est vrai, il y a un système qui, lorsqu'il y a une hyperpression, il y a une communication entre l'estomac partiellement exclu et le reste du tube. Mais avec la nouvelle technique que vous avez présentée, qui là où il y a l'applicature entrale, on réduit cette communication, et je pense pas que le système va baisser la pression malgré tout, parce que ça diminue le risque de slippage, ça c'est sûr. La complication la plus fréquente, apparemment pour ceux qui ont pratiqué ça, la complication la plus fréquente, c'est le slippage, mais sur de larges séries, des milliers de cas après, on ne peut pas encore s'annoncer sur d'éventuelles complications telles que les migrations, les abcès, tout ça. Ça, c'est la première question. La deuxième question, c'est une remarque. Je pense que c'est encore un bon device, un bon matériel, mais il est encore à améliorer.
Bon, la première très très longue question. C'était à propos des complications du reflux. Alors, ce qui est très intéressant, when you are doing an upper GI, you have an opacification of the gastric tube. And for the majority of patients, it's exactly the same image than we have with a sleeve. It's going through the pylorus and then in the small bowel. For some other patients, you have the opacification of the gastric tube, and then before going through the pylorus or at the same time, you have a retrograde opacification, but not in the gastric tube and in the esophagus, like with a sleeve, but always on all patients, we did for all patients upper the GI series, you have an opacification of the extruded part of the stomach. And there is a complete correlation for me between this image and the symptoms of reflux. These patients have no reflux at all. No reflux at all. We selected the patient, we have to be honest, we selected the patient at the beginning, choosing patient with no reflux, no hiatus hernia over 3 centimeters. But with time, we started to do some patient with reflux, with small hiatus hernia, we fix the hiatus like we are doing with a sleeve. And even with that, almost we don't see any reflux. So it's only clinical result. We need now, and in Italy, in Zingonia, with Stefano Olmi, they are trying to do some pH metry, some endoscopy before to all patients. And the idea is to do in 1 year after the Bariclip procedure to control everything by endoscopy, by manometry, by pH metry. So at that time, we'll have objective results. It's a short series. We need more patients, longer time, etc. But the majority of patients are not like with a sleeve, for sure.
Thank you.
Oui?
Thank you for this new technology. I think perhaps one day it can be approved by IFSO, like this year with one gastric mini bypass, one anastomosis mini bypass. But I think the idea of this perhaps give the other idea to do sleeve gastrectomy with one stapler. What do you think about also these techniques?
You mean with this new device?
SGS technique, stapler.
Yeah. The advantage of this new stapler, I think it's I remember well, is 20 centimeter or 24 centimeter length. I don't remember exactly. I think 20. But it's interesting because probably with that you will not have any slippage, any twist.
Yeah.
If you put well your tube, normally you will have a straight stapling. There is no risk of slippage, but slippage is one thing. Sorry? Twist. Sorry, no slippage. Twist. There is no. Probably will not see any twist if it's well performed. But same today, if you are doing properly by respecting a lot of principles to check anteriorly and posteriorly, to staple to staple just when you are between anteriorly and posteriorly, we don't see almost any twist. So it's interesting. The concept is interesting, but I have some concern.
I think that if you perform a sleeve without multiple stapler, or if you perform a sleeve without only one step, you perform a sleeve. The very difference between a Bariclip and a sleeve, that Bariclip is not a sleeve. When you put the shape, the final shape is similar, but it's not the same. When we spoke about reflux after Bariclip or after sleeve, in both cases we have a variation of depression inside the stomach, but this is not the only problem after the sleeve gastrectomy. When the reflux is a multifactorial outcome after the surgery. When you put a Bariclip, you have a very little dissection in the upper part of the stomach at the level of gastroesophageal junction. When you perform a sleeve, you remove a part of the stomach. When you perform a Roux-en-Y gastric bypass, you dissect the gastroesophageal junction. There are a lot of publications that show that after Roux-en-Y gastric bypass, you have a reflux. You have a weakly acid reflux, but you have a reflux. In this case, in the case of Bariclip, the dissection is small. We don't remove anything. And I think that we cannot compare the two techniques. Are two techniques completely different. It's the same error that we perform when we spoke about endosleeve. The endosleeve is not a sleeve, and the Bariclip is not a body sleeve. It is a Bariclip. It's not a completely another thing.
Another question was regarding the risk of erosion. It has been studied with engineer at the beginning. So it did animal study, mechanical study, etc. And at the end, it's a low pressure system. The pressure exerted on the stomach is around 4 centimeters of water. With a gastric band, it was at least 7-8 centimeters. We have now 1,200 patients. 2 erosion has been described. Probably we have, I don't know, 3, 5, 7, but the majority of these patients are probably asymptomatic, like we saw sometimes with gastric band. I checked the video of these 2 first complications. The first one has been described 1 month after the surgery. And on the video, we had, during the first procedure, they did an injury on the posterior stomach. So, and the migration was exactly at this level. So definitely the first one was a technical mistake. The second one has been described 11 months after the surgery, and the Bariclip was completely inside the stomach. So removal has been easy by endoscopy. I have no special explanation. I didn't see the first video, the video of this second surgery. It could happen like all foreign body around the stomach, but once again, it's a low pressure system. It's not like a gastric band. Band is an obstructive procedure. It's not a restrictive procedure.
Yeah, I think what was different to the band and the clip is that the migration we learned with the band that was depending on the technical of the perigastric technique or parsflagella technique. And the most important difference for me between the band and the clip is that the variation of the pressure when you are inflating or deflating the band and repeatedly doing this calibration of the band, you'll increase the risk of migration. And you don't have a calibration or by increasing or decreasing the pressure on the gastric wall with the clip. The pressure on the gastric wall is the same from the beginning till the end. But I completely agree that in the same time, we should wait more time to see the migration. We learn from the band that when we are seeing a percentage of the gastric band migration at 5 years old, 5 years follow-up is different than a 20 years follow-up the band. So the time is the most important.
Thank you very much for this talk about this new procedure and this innovation. My Last question to Patrick. Cette technique, elle date de combien de temps? Depuis quand le produit, la technique a été décrite? Nous sommes en 2023. Quel est son âge et quel est le roadmap et le développement géographique de cette technique?
Docteur Adala pose toujours plein de questions à une question. Bon, les premiers cas ont été faits maintenant, on rentre dans la 9e année. Les premiers cas ont été faits en 2013. In 2013, they started with human this surgery with human people. Before it was with animal and laboratory. So almost 8 years and a half, and we will be at 9 years now. Second thing, the roadmap.
Roadmap, yes. If it's possible to you to take 30 seconds for about the roadmap.
The future, you want?
Yes, sure.
Okay. So today, Bariclip has been developed by a small company, US company based in Florida. They will start the US FDA end of April. So in 3 months now, it will be normally not be a difficult FDA because FDA choose to compare Bariclip with medical treatment and diet and exercise with 1 year of follow-up. So I think results will be good for the Bariclips. This is the first thing. So they are starting the FDA in April. Normally they should have 150 cases to perform, possibly or probably in 9 or 10 centers. We choose the centers already. After that, we'll have at least 1 year of results before negotiation or publication and agreement from the US FDA. So at least we'll have the stamp FDA in 2 years and a half, 3 years from now.
Okay.
So for regarding the FDA, we have to wait and happy life for this new baby.
Thank you. Est-ce qu'il y a une remarque dans la salle? Merci pour la présence. Merci. شكرا على الحضور. شكرا على الاهتمام. شكرا حبيبي. Yes. On remercie tous ceux qui ont participé à mettre en place cette première réunion. نشكر كل من قام بمجهود للبداية في هذه المناسبة الأولى. نرجو أن تتجدد في الشهر القادم إن شاء الله. J'espère qu'il y aura plus de cas le mois prochain. La balle est lancée. La balle est lancée pour créer les ponts entre les différents pays de la Méditerranée et pour assumer ensemble les différents défis du traitement de l'obésité, du traitement chirurgical de l'obésité. Thank you very much.